Thank you, Dr. Sumita, for giving me this opportunity. So I can tell you gonioscopy is not an easy job. I'm here in glaucoma for last 46 years. I do not understand what is gonioscopy. I commit a mistake in very often when I see a patient and the patient referred from outside. Certain basic precautions that don't go do the gonioscopy when the corneal edematous. Control the intraocular pressure, take care that it takes little time, and then can do the gonioscopy. And you can choose any type of gonioscope, 1 mirror, 2 mirror, 3 mirror, 4 mirror, 6 mirrors, and anything. But 3 mirror is not indicated for gonioscopy. So don't use 3 mirror gonioscope for glaucoma purposes. Don't use that. And use gonioscope after you have examined the intraocular pressure and disc examination. Once you do gonioscopy, and then the disc examination becomes difficult. So it's always do the intraocular pressure first, then and disc examination, then do the gonioscopy. Sterilizing gonioscopy is also very important. Take special care that you are not applying the alcohol sponge over the flat surface, because that surface has got the anti-reflecting coating. So don't disturb the anti-reflecting coating at the flat surfaces. And minimal anesthesia. If you keep on putting anesthesia 3-4 times, cornea becomes little hazy corneal epithelium, and the gonioscopy becomes little difficult. And as usual, dim light for gonioscopy. Avoid light directly entering the antechamber through the pupil, and use minimum methyl cellulose without air bubble, but avoid pressure into the cornea. That is something very, very important. You can have instantaneous information. There are folds in the Descemet's membrane, folds in the cornea, white lines in the lower portion. If I examine the upper one, that will indicate that we have applied little more pressure. So don't apply any pressure in the glaucoma. Can you use the bright light? Yes, you have to use bright light as against the convention that you don't use any bright light, dark and very late light. It is not like that. You use bright light when you are looking for a neovascular glaucoma in the angle, when you are looking for a very thin exudative membrane in uveitic patients and you can't explain the intraocular pressure rise, then you can use little brighter light and even the brightest light to look for any neovascularization around, because that will help the retina people to change their treatment modalities. And you can see the exudative membrane in front of it, or it is the remnants of the embryonic remnants, very thin, glistening. Unless you use little bright light, you won't be able to appreciate that. And don't forget to put a drop of antibiotic at the end of your gonioscopy. And when you do the gonioscopy, the anterior surface of the gonioscopy, the anterior surface of the iris is convex. It will obstruct the light. Ask the patient to look down towards the mirror and examine it. If it is a flat iris surface, and you can ask the patient to go to look to the opposite side of the mirror, so that you can straightforward appreciation of the direct visualization of the angle on the opposite side, which will give you a better image quality. This is a common mistake. See, mirror means your indirect gonioscope. Indirect gonioscope is 12 o'clock is 6 o'clock. But 1 o'clock is not 11, or even 1 o'clock not in 11 o'clock this side. See the neovascularization as 11 o'clock is reflected or seen at 6 or at 7 o'clock, not at 6, not at 5 o'clock. So it is not the cross reflection. So it is the direct reflection which is opposite. It is not cross reflection, cross opposite. And there are always a confusion whether indentation gonioscopy, some people manipulative gonioscopy, some people say comprehensive gonioscopy, dynamic gonioscopy. There is a lot of complication, a lot of confusion. I have not understood it so far. Very late I understood that this is the difference. All these terminologies are meant whether you can do a gonioscopy 4 mirror or you can do a gonioscopy with 2 mirror. Everywhere you go, they will say, no, you cannot do the indentation gonioscopy 2 mirror. No. This is absolutely wrong. I'll tell you why. 4 mirror gonioscopy easy. You indent it at the center. Aqueous is pushed to the side, opens up the angle of the antechamber, you can see. Right? That will give the information whether this is a cynical angle closure or opposition angle closure. This will also give the idea that whether you can quantify it, whether the synechiae is breaking or is not breaking, and what is the extent of synechiae. The same type of information you get with the two-mirror gonioscope. The thing is, you do not know this procedure. This is an old procedure, and I do it every day. I demonstrate to my students every day practically. So don't go with the idea that indentation gonioscopy cannot be done with the two-mirror. Whether you call it the indentation gonioscopy, you do with the two-mirror, you say it is a manipulative gonioscopy, or it is a compressive gonioscopy, or you can say it is a dynamic gonioscopy. Whatever name you want to, fascinating name you have to give, you give it. But you can do it to gonioscopy, we can do an indentation or manipulation gonioscopy and get all the information like a 4-mirror, even at a 2-mirror. The only thing that you have to learn the technique, this is known as the Gorin's technique. Ask the patient to look down, little pressure on the lower part, it pushes the aqueous in the antechamber to the opposite side, and look for the opening of the angle in the opposite side. You can repeat the same thing in the upper half. So it is mandatory that you manipulate the gonioscope and see what to do, where to look for this. So identifying the structures is not very difficult. Those who do it regularly, I am not going to tell it. But the first thing you have to identify is the corneal wedge. Corneal wedge, the anterior swallow base line. Corneal wedge, you can see on the, do you have a, my pointer hai kya? कहाँ है? हाँ या. This is the corneal wedge. So the anterior of the cornea and this desmoid, this point is the corneal wedge, and this is the end of the desmoid membrane, and this is the point from where the angle structures are starting. So this is a very vital landmark you must identify. If you are examining from the lower half, so you see this one in the lower, this one the upper one, you can see this wedge, and then wedge ends here, I can see the structures. In the same way, there is a pigment lining, this is the Sampolis line. But identify, the first thing is the wedge, corneal wedge. So this is something very important. And there is a lot of confusion, what is the grade 1, grade 2, grade 3, grade 4 pigmentation. Appreciate that there is no pigmentation here, grade 1, grade 2, grade 3, grade 4 pigmentation. So you must appreciate whether when you account for the pressure rise, so the grade 3 and grade 4 pigmentation in the angle is more important, you must appreciate that. There is always a confusion, what is this angle recess and angle recess area. Nobody is very clear about the angle recess, I can tell you. But the angle recess represents the dipping of the iris. You can follow the iris surface from the center, and the dipping of the iris as it takes insertion into the ciliary body. So this is which one is the angle recess. This is the scleral spot, this is the angle recess, and this is the anterior segment OCT. You can see the angle recess here. And what is angle recess area? If you draw a line from the scleral spot 500 microns and draw a line, this is the angle recess area. So this is for the other eye. So be clear about the angle recess areas. And grading of antechamber of the angle of antechamber by the Schaeffer's classification. I think as we advance in the glaucoma knowledge, I think Schaeffer's classification, the old classification, forget about the Schaeffer's classification. Just remember one or two aspects in the Schaeffer's classification, that the grade of 40 and 10, this is this thing, open angle and narrow angle or slit. This is the only information you get from this. And the inference you draw is clinical significance. But for a glaucoma practitioner, this type of classification is most inadequate. Smith's classification is certainly a much better classification, little more complicated. I think all of you can, if you do start doing it for little time, maybe if in 10 cases, 20 cases, you'll be able to master this technique of Smith classification, more elaborate but more informative. Whether this is going to cause angle close or not is matter of this thing. You can always appreciate that. The three parameters they have taken. You can see the insertion of the iris root at different levels. So this is insertion of the iris root. Second parameter is the angular width of the angle recess. Angular width of the angle recess. You can see the angle recess, it is 40 degrees, 30 degrees, 20 degrees or 10 degrees, and this is configuration of the peripheral iris in the periphery. Configuration may be queer, may be regular, or may be stiff configuration. So this is the type of analysis you always do, and go for the plateau iris configuration. Always the most complicated aspect is the plateau iris configuration, and this is the sudden dip. And configuration, you must understand there are 4 areas of configuration, iris configuration. As far as the plateau iris is concerned, anterior 2 halves is the complete configuration, and the plateau iris and possibility of angle closure is much higher. And the second one is third one, and they can see this. So if the attachment is after the dilatation, the possibility of closure is at the level of the Schlem's canal, so you get it is 3. Or if it is on the anterior swell base line, it is 1. That means the possibility of angle closure with the plateau iris configuration has to be very, very critically analyzed. One thing which this is plateau iris syndrome, when the intraocular pressure starts increasing, you call it a syndrome. And another confusion is the angle creeping angle closure. A part of the angle is closed and part of the this is creeping angle closure. This is getting closed vertically as well as horizontally. So this is a picture of the creeping angle closure. And this is a new concept. For so many years nobody has thought of, and I just came to know about it. It just struck me. We are all considering about the configuration of the iris attachment to different areas, whether this iris is plateau iris, regular iris or convex iris. Nobody has ever thought of thinking the wall of the iris, wall of the angle. There is a vertical width of the angle wall. I am not talking about the angular width of the angular recess. This is my own thought. I certainly appreciate if you suggest on this. So the main thing will be the width of this area to the ciliary body band from the anterior swell base line. Say this is for the ophthalmic. I'll take just a minute. So this is in ophthalmic eye. So this see the width. So for myopic eye, see the width. See the normal eye, see the width. And hypermetropic eye, this is non-ophthalmic eye, is this. Is there any importance of this distance as far as the glaucoma is concerned? We have not bothered about it. I think this is one possible area where you can really try to investigate and see. The next step, I was thinking of doing the anterior segment OCT and find out what is the length of this area and what is the implications as far as the glaucoma treatment is concerned and diagnosis is concerned. So that is that area which I am working on. I think this has got great possibility because we have never thought of the width of the angle wall in any form. And ultimately what you have to do is you have to identify and do a goniogram and see that your records are complete. Thank you very much. Any question, I will be delighted to answer.
Sir, you told that prior to gonioscopy, you do explanation, then fundus, evaluation, then.
Yeah.
Which one is preferable prior to fundus examination, a dye or one lubricant?
Pardon?
Which one is preferable prior to fundus examination, a dye or a lubricant? Because prior to examination, we use dye.
You use?
Dye.
What the fluorescent dye?
So which one is preferable? I stain my cornea with the dye, and later on I stain my cornea with a lubricant.
Now stain your cornea with a lubricant. I didn't understand.
While doing gonioscopy,
Yeah, yeah,
my cornea is in touch with lubricant.
yeah.
But during my apprenticeship,
Uh-huh.
cornea is in touch with a color.
Now, if I've used the appellation tonometer and you use the fluorescent dye, make sure that you clean it, you wash it very thoroughly, means once, twice, and see that there is no extra fluorescent in the angle or in the corneal.
Same is applicable for gonioscopy.
Gonioscope you have, if I would the gonioscope for 2-mirror gonioscope and the 4-mirror gonioscope, you don't need any lubricating agent. But if you are using 2-mirror, I think you have to again wash it very clearly before doing it. So, otherwise the visibility will be little poorer.